Thank you, Mr. Chairman. Let me start by answering a couple of COVID-19 related questions posed by Dr. Tan Wu Ming. He asked about excess death rate. I reported in the House late last year that as at end June 2022, our age standardized death rate throughout the pandemic was 549.9 per 100,000 person years. 549.9, and this is higher than the base rate, which we used 2019, which is 525 per 100,000 person years. So there's some excess death. So as at end December 2022, the number has gone up further and slightly to 555.7. And this is expected because we are taking in the mortality of all our major infection waves throughout the pandemic. And this indicates an excess death rate of 30.7 per 100,000 person years. And nevertheless, due to the concerted efforts of Singaporeans, we remain one of the countries with the lowest mortality rate and excess death rate in the world throughout the COVID-19 pandemic. Dr. Tan also asked about strengthening our vaccine capability. This is something we are actively looking at, both in terms of building up our R&D capabilities and also anchoring local manufacturing capabilities here. I will give a fuller update at the subsequent sitting because we are going to table our full after-action review in this House. So this will take place not too long after the COS debate. A major after-effect of COVID-19 pandemic is that it has inspired us to accelerate the changes to our healthcare system. And as a result, the healthcare system is now at a very decisive stage of a major transformation, working off a foundation that took many, many years to build. And now we look at healthcare system not as one system, but as three interlinked systems. And first, the acute care system, which is mature, well-developed. This is a system comprising hospitals, specialist clinics, treating the sick. Second, the population health system. I would say this is a teenager or adolescents. We are putting more emphasis on this through preventive care, through Healthier SG. And third, the aged care system. And I think this one is a baby, still developing. We need aged care to take place predominantly in the community and not nursing homes. The imperative of this transformation is our rapidly aging population, which I think it is the biggest social development for this generation. The impetus to act now is COVID-19, which made things that hitherto was impossible, now possible. In crisis, we made it possible. So don't waste the crisis. And most importantly, through the crisis brought to the forefront the power of preventive care, like good hygiene, screening tests, and vaccinations. Mr. Chairman, today I will give the House an update on the three systems and answer questions at the same time. But before that, there are a few common foundational issues undergirding all three healthcare systems, which my colleagues in MOH will address. First, we need the right size and quality of manpower. SBS Rahayu will be speaking on this, but let me make a few comments first. We need, based on our projections, to increase the number of nurses and support care staff by about 40%, from 49,000 now to 69,000 in 2030. I've explained in the House before that with a rising population of seniors who will fall sick more often and the shrinking population of new local entrants into the workforce, the numbers simply do not add up. We will not have enough local healthcare workers to support our healthcare needs. So we have to do first whatever we can to develop our local pipeline of talent, including some of the suggestions Mr. Gerald Giam put forward, attract retired nurses to return, serve as locum, increase male participation, that would be most welcome, but we still need to complement it with foreign healthcare workers from varied sources. This, I think, various members raised the issue about welfare of workers. I thank you for this. But fundamentally, the best safeguard for their welfare is to have sufficient manpower, no sufficient manpower, and you have people who are so responsible, they're going to burn their weekends, they're going to burn their rest days, and so on. You have to simply beef up the manpower resources. So SPS Rahayu will speak more about it. Then as for foreign healthcare workers who become valuable members of our team and demonstrated commitment to Singapore, we should be prepared to integrate them into our society, just as we do for many foreign professionals. Now, at the same time, and a few MPs have raised this, society needs to appreciate and respect healthcare workers. Actually, the great majority of our patients and their loved ones and their family members, they do. And this is hugely motivating for our healthcare workers. But abuse and harassment by a small minority is a rising issue in our healthcare institutions. And this is not acceptable, and we will need to take a firmer stand against this. We need, as Mr. Ang Wei Neng suggested, a consistent understanding across the healthcare system on what constitutes abuse of healthcare workers. We need to then empower hospitals to take a firmer stand against such abuse. And when hospitals take such firmer stand against abuse, the hospitals must feel confident that their management, the Ministry of Health, the Minister, and hopefully this House and the public will stand behind them in protecting our healthcare workers against abuse. MOH has convened a work group to study this issue. They have completed their work. We will be sharing the findings on MOH's plans later this month. Second undergirding issue is we need the right IT systems and tools to allow patients' key health data to be collected and shared across healthcare providers safely and securely to ensure seamless and integrated care. SMS Janil will elaborate on this. And third, we also need to improve the support system and safety net for vulnerable groups, especially to the lower-income families. Minister Masagos will elaborate on this. Now let me move to talk about the three healthcare systems. And let me start with the one we are most familiar with, and briefly, the acute care system. We have about 11,000 public hospital beds today, and we intend to add 1,900 more public hospital beds over the next 5 years. And this will mainly come from Woodlands Health Campus, which we are waiting eagerly for. And this will progressively start operations from end of this year. Then Tan Tock Seng Hospital Integrated Care Hub will also start operations this year. Preparation works for the redevelopment of Alexandra Hospital and the new Eastern Integrated Health Campus are also in progress. While not part of the acute care system, polyclinics are a very important part of our healthcare ecosystem. And the Sembawang Polyclinic will start operation second half of this year, and so too the Tampines North Polyclinics. Another 8 will come on stream by 2030. We need to have adequate hospital capacity, but we should not overbuild, or worse, think that the solution to future challenges of healthcare lies only in infrastructure and number of beds. Ultimately, with an aging population, we need to become healthier. And this brings us to the second system, which is the population health system. We are building it up through Healthier SG. Dr. Tan Wu Ming, Dr. Lim Wee Kiak, Mr. Ang Wei Neng, Ms. Ng Ling Ling, and probably a couple more others, they have asked for updates on Healthier SG. Let me provide them by walking through the experience of Healthier SG. We want each of our residents to enroll with a family doctor to build a long-term patient-doctor relationship. We think the doctor is best placed to guide a resident to better health. And that makes family doctors the linchpin of Healthier SG, the most important component. And therefore, we have been engaging our private sector GP to co-develop Healthier SG. We are supporting GPs in many ways: IT grants, annual service fees for Healthier SG when they take care of enrolled participants. And this is a new stream of revenue for the GPs for managing the health of enrolled residents. We will also be fully funding preventive services like nationally recommended vaccinations and health screenings for enrolled Singaporeans. So GPs will very likely have to deliver more of such services, which is another source of revenue. And we have been explaining to GPs that with greater investment in preventive care, the primary care will grow both in terms of size and importance. I thank Ms. Ng Ling Ling for reminding me of that very simple back-of-envelope calculation. The money is there, the investment is there, the pie will grow. But the GPs will incur more costs, but they will also earn more fee-based incomes and services-based incomes from the government. It is voluntary for GPs to be a healthier SG clinic. We have about 1,600 GP clinics in Singapore focused on primary care. Our assessment is that great majority appreciates the objective of healthier SG. They think it's a move that should have come earlier, and they want to be part of it. But the sums have to work for them, and we are working with them closely. And we hope to secure the great majority of them to be our partners in healthier SG eventually. I announced last week that we will launch healthier SG enrollment for Singaporeans aged 60 and above in July this year. I also announced that we will launch a pre-enrollment exercise in May 2023. And this is an early bird exercise. Who does it apply to? Those aged 40 and above, already have chronic illnesses, and regularly visit their GPs. But their GPs need to sign up for healthier SG. And if they haven't signed up, please try to persuade your GPs to sign up. And this will ensure that this group of patients who need healthier SG the most do not get crowded out. Mr. Ang Wei Neng suggested using health carnivals to encourage sign-ups and volunteer Pioneer Division to be the first. We are keen to take it up, and we'll discuss with you as well. And I hope you are the pioneer. You are indeed the pioneer, and many more community and grassroots organizations will come after you. Yeah. You come second after Sembawang. From July 2023, the first tranche of healthier SG benefits will also kick in. This includes, first, a first healthier SG doctor consultation, which will be fully subsidized by government. 2, once the first consultation is completed, you will be awarded 3,000 health points worth $20. I did a check. To earn 3,000 health points using Health 365, you must walk 5,000 steps for 300 days. So 3,000 health points is quite a lot, no? And this is MOH's way of saying, well done. Welcome to healthier SG. 3, nationally recommended health screenings and vaccinations like influenza and mammograms will be free of charge for eligible residents. 4, after seeing the doctor, you want to heed his advice and to be more physically active, our community organizations will be organizing more activities near your home. And participation will earn you health points. Dr. Tan Wu Ming talked about sessions being terminated. There was a time where we were cost conscious, we want to be cost effective, those with fewer participants were suspended. I think we have changed our approach because of healthier SG, we want to provide a stronger support. So even for those with lower participation rate, we want to work with the local community, beef up the participation, and give sufficient lead time for us to be able to do that. Yeah. But what has been suspended, I'm afraid we can't undo, so please erase that from your memory, and let's look forward. But ultimately, the best payback is better health for everybody. In early 2024, a second tranche of benefits, which will require more operational preparation, will kick in. This includes, 1, enhanced subsidy for chronic drugs at GP clinics. This needs a little bit of explanation. Today, CHARS already provides significant subsidies for patients with low chronic medication needs. So just with their CHARS subsidies, they pay $0 or very little for their visits and medications. However, there are patients with complex chronic diseases who need several drugs and medication, and the current CHARS benefits are not enough for them. Hence, these patients tend to go to polyclinics to get their subsidized drugs. Under Healthier SG, this group of patients have the choice this group of patients have the choice to get their supply of polyclinic chronic drugs at healthier SG-GP clinics at around the same price as polyclinic drugs. This is because we will provide a new healthier SG CHARS chronic tier subsidy for selected drugs, and they will be available at your enrolled healthier SG-GP clinic. I should emphasize that this healthier SG chronic tier, CHARS chronic tier, is an option for this group of patients. It's an option. Because we know that some of these patients in this group, they are used to certain brands of drugs, and they prefer to get it from their GPs, even though the drugs are not subsidized. So now we make the subsidized and cheaper alternatives used by polyclinics available to these patients through their private GP clinics. But they are not compelled to switch. They can stay with the unsubsidized drugs that they are used to if they wish to. Another benefit is the removal of cash co-payment when using Medisave for chronic treatment. Patients can use Medisave to pay their bills fully up to the withdrawal limit. This will also be effective early 2024. Finally, Ms. Ng Ling Ling asked about traditional Chinese medicine. We are working closely with TCM practitioners by providing more support on research and development to generate evidence on the efficacies of TCM. There will be more developments in this area, which I will update the House when ready. Now let me move on to the third system, which is the aged care system. Several MPs have asked about this. We are building many more nursing homes, doubling from 16,000 in 2020 to over 31,000 in 2030. Nursing homes have indeed provided important support to many families with frail parents. It is highly subsidized and supports families who are no longer able to take care of their loved ones at home. However, building more nursing homes is not a sustainable long-term solution. We run the risk of becoming over-reliant on it. Why do I say that? Because the worst enemy of the aged is often not diseases, but isolation and loneliness. Without companionship and love of family members or friends, the loss of function will hasten and they become frail very quickly. As I mentioned in this House before, research shows that the impact of loneliness on an elderly is equivalent to smoking 50 cigarettes a day. Our seniors need friends, relationships, love, activities around them. They need to feel active and purposeful, doing full-time work, part-time work, volunteer work, take walks in the park, hear the laughter of children, occasionally get into a squabble with their kakis. All this keeps them healthy, These things can even reverse frailty in certain instances. But they can happen only if the seniors can age actively in the community. MND has announced that they are building more community care apartments. It will help, but it will not cater to the great majority. Therefore, what is more important is for seniors to be able to age in their current homes, which hold unique memories. And to do so, we can leverage two important assets. First, our HDB estates. They are designed with many common spaces for interaction amongst residents. Void decks, you've got exercise corners, coffee shops, supermarkets, hawker centers. They serve a different imperative in the early years of our nation building, but now these common spaces offer opportunities for seniors to age healthily in the community. Second, our community partners, who have been providing social care and support in our housing estates, and they have built up very precious personal relationships with residents. We have been working with them to implement pilot programs for aging in communities. Recently, I visited Montfort Care's Active Aging Center, AAC, at Marine Parade. They told me there are 5,000 seniors in the area they are in charge of, and they have so far identified 400 seniors living alone. And this 400 is their top priority for engagement. So like MOH, they know from experience the pain and detriment of loneliness. Montfort is hosting many activities for seniors, and like many AAC partners I visited, Montfort came to the conclusion, as everybody, how best to attract seniors, and is to makan together. So once or twice a week, get volunteers to prepare the food, get donors to donate the food, then volunteers to prepare the food, serve it in a nice environment, like a nicely done up void deck. And seniors will come and gather. From there, they make friends. Then they start to watch out for each other. The center staff can then further engage them to ensure that they are taking their medications, they are going through their health screenings, and they can monitor their health. The other attraction is the gym. I didn't know that until I visited many of them. Especially we have many gin tonic now on the ground. Many seniors who don't like to leave their home will go to the gym. It's called gym tonic, J-Y-M tonic. Yeah, it's a bit corny, it's not gin tonic. Yeah. Many seniors who don't like to leave their homes will come to the gym. I suspect they heard enough stories of how gym work actually strengthened them, and people who were immobile are able to walk again, and even reverse frailty in certain circumstances. We are putting these grounds experiences together into an effective and workable operating model for all AACs, even as we expand the network. To do this well, our community partners, they will need stronger support in both money and manpower. MOH is studying how best to strengthen our support to the AACs. And this is potentially another major healthcare program alongside Healthier SG. This is urgent work. We are racing against time because the pace of aging in Singapore is relentless. But if done well, this will be one of the best gifts to our seniors. Mr. Chairman, over the years, MOH has been explaining the need to shift healthcare from hospitals to the community. And with the 3 healthcare systems, we are making this into a concrete reality. But if care is shifting from hospitals to community, so must other aspects of healthcare. We need to be service-centric, not premises-centric. Take regulation, for example. We cannot just have standards and rules for hospitals and clinics. We need them for wherever healthcare services are delivered, including senior centers in community, residential homes, mobile clinics, or even remotely via telemedicine. That is one of the key purposes of the Healthcare Services Amendment Bill, which we will present to the House at the end of the COS debate. Patient data is another good example. They need to flow across different healthcare providers and settings. That is why we will be presenting the Health Information Bill to improve the current situation of data collection and sharing. Likewise, the same argument can be made of healthcare financing for patients. The healthcare financing framework, which is S+3 M's, namely subsidies, MediShield Life, MediSave, and MediFund, they must extend beyond hospitals to wherever healthcare services are delivered. We are therefore undertaking a review of our healthcare financing framework to make it more premises neutral. But this will take some time. It's a complicated issue. But in the meantime, we will make 3 smaller, no-regrets moves. First, MediSave claims for home care. Dr. Tang Wu Ming have told the story of Ama twice, once during white paper on Healthier SG and once just a couple hours ago. And he put out a compelling case why financing schemes need to be premises neutral to support patients like Ama, who is immobile, homebound, and find it challenging to visit the polyclinic or the hospitals, and therefore they have to rely on home care. Hence, in the second half of this year, we will extend the use of MediSave to homebound patients receiving home medical care. They will be able to tap on the MediSave 500, 700 and Flexi MediSave schemes. And as a start, this will apply to 25 home medical and home nursing providers that are receiving subvention and support from MOH. Collectively, they serve close to 10,000 patients. When the scheme stabilizes, we will consider extending to the rest of the service providers. Dr. Tan Wu Ming also suggested allowing patients to take their blood tests at polyclinics before their surgery and to standardize their forms. We will look into that, but we are mindful not to add further workload to the polyclinics, especially with Healthier SG coming on stream, and they are extremely busy, but let us study the proposal carefully. Second thing we will do is normalize telehealth for care delivery. During COVID-19 pandemic, we wanted healthy individuals to recover from COVID-19 infections at home so as to minimize their visits to the clinics. Telehealth made this possible. Infected persons isolated at home, they could seek consultation from a doctor online and have medications sent to them. Doctors too can now leverage technology to attend and care for more patients. To support and encourage the use of telehealth during the pandemic, we extended usage of MediSave and CHARS chronic subsidies for teleconsultations for chronic disease management. And this policy was meant to be time-bound, effective only during the period of the pandemic. But now we are in DOSCON green. We will not lapse it, because telehealth has become widely accepted and demonstrated to be effective. Hence, we have decided to continue the pandemic arrangement and normalize the use of appropriate telehealth and make it part of routine chronic disease management. Third thing, stronger support for palliative care. Mr. Yip Hong Wing, Mr. Xie Yao Qian have asked about this. Survey findings consistently show that the great majority of Singaporeans, they prefer to pass on at home, in familiar surroundings, in the presence of loved ones, instead of an unfamiliar hospital surrounding. However, currently, 3 in 5 deaths still happen in hospitals, and we have a long way to go in fulfilling the wishes of Singaporeans. Hence, we are improving the clinical protocols in hospitals. We are upskilling providers to develop general palliative care capabilities. We are engaging in early conversations with patients and their loved ones on their wishes. Later this year, MOH will be embarking on an outreach effort to encourage more Singaporeans to plan ahead with a lasting power of attorney and advanced care plan. But we also need to work on expanding the capacity of the palliative care sector. Community palliative care providers, namely HCA, RCC, Dover Park, they have been doing a tremendous job. They provide 3 modes of palliative care: at home, in a day hospice, or in an inpatient hospice. They have also been raising significant amount of charity dollars every year to complement government's funding to support their operations. However, their capacity are heavily utilized. To unlock their capacity constraints, hospices will need additional resources. At the same time, instead of having 3 funding formulas and funding streams for different hospital settings, hospice settings, home, day, inpatient, we can bundle them into 1 per patient funding rate, set it at an adequate level, and then empower the hospice to decide which settings are most suitable, depending on the care needs of the patients and also their family circumstances. We will pilot this new approach with Dover Park Hospice, which is working closely with Tan Tock Seng Hospital. We will grant them more resources through a new bundled per patient funding rates. And we will learn from the pilot, review the arrangements with a view to mainstream the scheme next year. Let me end this section with some comments on questions raised on healthcare costs posed by Dr. Lim Wee Kiat and Mr. Xie Yao Qian. Healthcare inflation in 2021 is 1.1%, 2022 is 2.2%. And this is calculated post-subsidies and significantly lower than general inflation in both years. We will continue to keep healthcare costs affordable through our S+3Ms framework. And low-income Singaporeans in particular can be assured that additional financial assistance will be available to you if you need them. We will also extend financial assistance. This is a question raised by Mr. Xie Yao-Chen. We will extend financial assistance on a case-by-case basis to needy permanent residents, especially those with a strong nexus to Singaporeans. However, for the great majority of Singaporeans who are healthy, the best way to keep healthcare costs low is to stay healthy. This is another reason why Healthier SG, aging in communities, are two top priorities now. Mr. Chairman, in Mandarin, please. 我相信大家都注意到，新加坡人口正在迅速的老龄化，邻里的年长者越来越多。无论是对社会和家庭、医疗体系，还是国家财政，我们的负担会越来越沉重。人口老龄化是大势所趋，但这不等于说我们毫无对策，不等于说我们要举手投降。人口结构的变化我们不能改变，但对年龄的看法我们可以改变。许多65岁以上的人，年纪虽大，但人不老，就算人老，心也不老。最近在选区走门户的时候，遇到了一个安迪，他很亲切地对我说：“王部长啊，你很年轻哎，我都要90岁了，你才60多。”所以我回答安迪啊，我才53啊。不过安迪他毫不尴尬地说：“哎呀，我都要90岁，你们现在的人50多、60多，看起来都一样啊。”我事后想想，其实安迪说的没有错嘞。好像我祖母50多岁去世了，我从来没有见过她。我的祖父60多岁癌症去世，在我记忆中他是憔悴的，他是苍老的，60几岁。现在许多60几岁的安哥安迪看起来都身强体壮，非常活跃，一点也不老，跟我看起来差不多一样。随着生活素质的提升，新加坡人呢，我们的平均寿命不断的增加。什么年龄才算老？最好的答案，照顾好身体，保持健康。你做到这点，就可以不认老，不要说老认老。保持健康当然是个人的责任，但是政府也会以适当的政策，更好的照顾我们的年长者。今天让我大略解释几项重要的方针。第一，就是卫生部正在积极筹备即将出炉的健康 SG 计划。从今年7月开始，我们将开始邀请60岁以上的国人前来报名，每人可以选择一名家庭医生作为你长远的健康伙伴。第一次的门诊是免费的，政府帮你还。接受门诊服务后，政府也会给予价值20元的奖励。过后，您每年在卫生部建议下接种的疫苗做的身体检测也将是免费的，政府帮你还。卫生部会跟联络所、基层组织合作，帮大家报名。第二是尽量让年长者能在自己熟悉的社区里安享晚年。人们步入晚年时，其实最害怕、最畏惧的，往往不是疾病，而是孤独感。一个年长者一旦失去了亲友的陪伴、关怀和爱护，健康就会日况愈下，身体很快就变成虚弱了。原地养老，有家人、邻居、朋友、社区义工的陪伴，可以尽量保持健康，甚至扭转身体逐渐虚弱的这个情况。这是一个可以达到的愿景，但是不能只靠卫生部的一己之力。很庆幸的是，我们现在已经有很多社区伙伴在各个组屋区内为社区提供 社区护理服务，而且跟居民建了很宝贵的默契。我最近到马林百列一家咖啡厅，名字很特别，叫做独一无二，不是独一无二，是独一无二。原因是因为这个咖啡厅就在大牌52楼下。这是蒙福关怀，就是 Montfort Care 活跃乐龄中心的设施之一。在那里协助乐龄朋友的义工，他们自己也是乐龄人士，每周会1-2天到中心去，准备一些美食，招待住在附近的年长者。然后大家有的切肉，有的打倒给，有的煮菜，有的摆设餐具，大家一起忙。一旦一起用餐，就开始交朋友，就慢慢的互相照顾，彼此照顾健康。像独一无二这样的地方，目前是靠善心人募捐来支持运作。政府会考虑如何加强资助，让这样的计划能够遍布新加坡。第三，我们会调整保健储蓄的政策。现在一些年长的国人需要使用轮椅或卧病在床，不得不请医生上门来看病。但是现行的政策下，在家看病不能动用保健储蓄。今年的下半年，我们将调整，让这类病人也能动用保健储蓄，从而减低这些行动不方便年长者的医疗费用负担。第四，这个触及到一个比较敏感的课题，就是临终的安排。很多国人不想谈，很多人说不要谈，因为不吉利，很搬当。但近几年的调查中，许多国人透露，在家终老能够在至亲陪同下走完人生旅途，其实是他们的心愿。要满足国人这方面的心愿，我们还有一些努力的空间。接下来我们会和提供持怀护理服务的托福员，就是 Dover Park， 以及跟他们紧密合作的陈笃生医院，展开一项实行计划。在实行计划下，我们会提供更多的津贴补助，鼓励他们扩充服务。我们也将授权给托福员，让他们能够根据病人的护理需求和家庭情况，决定病人应该接受怎么样的持怀服务。如果一切顺利，我们预计明年就会把这一项安排纳入我们的主流医疗体系里。我希望在政府、企业、社区还有国人通力合作下，我们能够实现医疗体系的改革，改变社会对老龄化的观念，让年长者在晚年时可以活得更充实、幸福、快乐、安详。Mr. Chairman, let me conclude by addressing Mr. Henry Quek's question on longevity science. The Geriatric Education and Research Institute and the Center for Healthy Longevity, as well as other similar centers, they are doing very good work. But in the transformation of healthcare, we are dealing with a much broader and much more fundamental questions. They are, what is medical science? How does it translate to public policy? I think the definition of medical science lies on a spectrum. At one end, medicine is a frontier science. As a matter of life and death, it attracts a lot of R&D, including very exciting work on human longevity. Some of the advances sounds like science fiction. Today, you can 3D print body replacement parts. You can teach your cells to fight a disease. You can edit genes to treat cancer. Many medical moonshots have been fired. But we need to exercise caution when translating medicine as a frontier science, no matter how promising and exciting, into public health policy. Emerging treatments usually work for exceptional cases. While these get reported in the media, they usually are not suitable for the majority of patients. And furthermore, they are, by nature, very expensive. So if we are not wise or careful in the development of frontier medical science, the country can end up paying a lot, including wiping out savings of many people for very little good outcomes. We have to ensure that standard clinical practices and healthcare policies do not run ahead of the evidence of clinical benefit and cost effectiveness. And that's one end of medical science. In the broad middle, medicine is a biological science. This is where medicine finds wide applications in the treatment of diseases. It is the heartbeat of our acute care system. It has improved lives all over the world. When people unfortunately fall sick, hospitals do their best to treat them. Safety nets are set up to try to make healthcare costs affordable. But make no mistake, we don't like sickness, and all countries in the world hope that demand for medical care is as low as possible. Therefore, the system must be designed with an emphasis on personal responsibility to ensure prudence and discipline in spending on sickness. And that is why co-payment of medical bills and insurance payouts remain an important principle of our system. Then there's the other end of the spectrum. And here, medicine comprises relatively simple and general interventions that apply to entire populations. Adequate sleep, eat healthily, exercise regularly, don't smoke, don't doctor hop, go for periodic screenings and vaccinations. Unlike medicine in hospitals where we wish for less, we want more of such socially good medicine that enhances health is wealth, that enhances health, well-being, and productivity. As Rudolf Virchow, the father of modern pathology and social medicine, he famously said in 1848, medicine is a social science, and politics is medicine at a larger scale. But this is, of course, 1848. However, while the benefits are significant in this spectrum, many people are unable to bring themselves to do the simple things that make us healthier. Because eating well, exercise, etc., takes effort, sacrifice, perseverance. The rewards happen gradually and later, and it denies the all-too human need for instant gratification. Hence, our public policies need to recognize the positive externalities of this spectrum of medicine and overcome and compensate for this hesitancy in order to maximize social good. And this is the driving force behind the healthcare transformation that we are witnessing. So through Healthier SG, we have decided to make preventive care, like nationally recommended health screenings and vaccinations, like public parks and libraries, all over and free. We need to invest in infrastructure and systems that keep people healthy, just as we do for public transport and clean water. We cannot sweat those minority of abuse cases and let them dictate the overall design of our preventive care system, just like how we designed the vaccination system during COVID-19 pandemic. We need to mobilize the support of communities and partners to deliver preventive care well, similar to how we say it takes a village to raise our children. We need every individual to play a part in health and assume personal responsibility, just like national defense. It is a new realm of thinking in healthcare policy, but the considerations is not at all unfamiliar in public policy making. Mr. Chairman, our healthcare system has always reflected the face of Singapore. In the 1960s, we had a lean, cost-efficient system suited to a mainly young and vigorous people. Today, we need a more mature and multifaceted healthcare system. 3 systems, in fact, spanning frontier, biological, and social sciences so as to provide for the more complex needs and opportunities of an aging population. Today, we have, through the crisis of COVID, and all that we as a nation have learned in overcoming it, a powerful impetus to act decisively with resolve and extraordinary will to see us through this necessary transformation. And if it's true that politics is medicine on a larger scale, we in this House have a duty to ensure that we, our families, and fellow Singaporeans will enjoy good health for generations to come. I ask for your support. Thank you.